Hello, this is Dr. Darsh Anoop Singh Sandhu, and I'm going to present my paper on high resolution ultrasonography for evaluation of rotator cable in patients with rotator cuff tears. So, rotator cuff tears are most common cause of shoulder disability and can lead to significant pain and functional limitation in an individual, causing long-term implications to the health system and economy. The rotator cable is transversely oriented fibrous band running in the anteroposterior direction in relation to the undersurface of the supraspinatus tendon, continuous with the coracohumeral ligament anteriorly and terminating posteriorly at the level of inferior border of infraspinatus tendon. The rotator cable marks out a crescent-shaped region of relative tendon hypovascularity known as rotator crescent, where rotator cuff tendon tears occur most frequently. It is performed. It is formed by tendinous insertions of supraspinatus and infraspinatus contained within an avascular zone. The cable crescent complex has been linked to a suspension bridge where the biomechanical load is transmitted to the cable, which distributes the stress to the humerus through its anterior and posterior body anchors on the humeral head. Hence, the cable could play a force transmission role that assists the rotator cuff tendons. Therefore, small rotator cuff tears within the crescent with an intact cable may manifest clinically without loss of shoulder strength, but a substantial decrease in force transmission through the supraspinatus tendon may occur when there is involvement of the rotator cable attachments. On that account, an intact rotator cable could possibly attenuate the adverse consequences of rotator cuff tear on glenohumeral biomechanics. The cable crescent complex can be further divided into two different functional classes, crescent dominant and cable dominant. The latter shows thinning of crescent with thickening of cable and is seen more commonly amongst the older age groups. The thickened cable is believed to undergo hypertrophy with an advancing age, as cable has to take an increasing load with age and is believed to play a role in stress shielding of the crescent. Ultrasonography can be used to successfully depict the rotator cable and show consistent results in asymptomatic shoulders. The rotator cable is depicted as a hyperechoic fibrillar structure perpendicular to the orientation of supraspinatus tendon. The non-visualization of rotator cable on ultrasonography is associated with symptomatic rotator cuff tears, larger tear size, and greater muscular atrophy. Therefore, less severe tears are associated with an intact cable, which is well visualized on ultrasonography. So this is the diagram. We can all see supraspinatus, infraspinatus attachments, rotator cable, and crescent and attachments. Aim of the study is to evaluate sonographic visualization of rotator cable in patients of partial and full thickness rotator cuff tears. And inclusion exclusion criteria are as given in the screen. Technique, we did it using linear array of transduce using linear probe on G8 machine. The patient was made to sit in the position of straight, and arm of the affected side was placed on cross and modified cross positions alternatively. The shoulder was examined along the anterior, superior, and posterior aspects in the long and short axis for optimal visualization of rotator cable. And the grayscale technique was used. Depth, gain, and dynamic range was adjusted appropriately for each participant to ensure optimal visualization of rotator cable with the surrounding tendons and bony structures. This is a diagram showing rotator crescent cases. So, the shoulder, it was aggravated with right arm movement. On clinical examination, patient complained of pain on abduction and internal rotation of the right arm. Mild tenderness was present in the infraclavicular region. Imaging technique, patient was made to sit straight and the arm was examined in neutral and class positions alternatively. Sonographic imaging showed a grade 1 partial tear of the subscapularis tendon. The coracohumeral and superior glenohumeral ligaments were well visualized. On further imaging, the right shoulder in cross position, the rotator cable was well visualized in this patient, as you can see in the sonographic images. A 64-year-old male, 64-year-old female presented case 2 with complaints of pain in the right shoulder with difficulty in movement, especially inability to lift the upper arm. On clinical examination, patient complained of pain on overhead abduction and external rotation of right shoulder. Imaging feature, the patient was made to sit straight and arm was examined in neutral and cross position alternatively. Sonographic examination of the right shoulder showed high-grade partial thickness tear of the anterior fibers of supraspinatus tendon. Moderate amount of fluid with thickening of the tendon sheath was noted along the long head of biceps tendon. Cortical irregularity of the humeral head was also noted. On further examination of the patient in cross position, there is evident thickening of coracohumeral ligament and rotator cuff cable wasn't well visualized in this patient, as you can see in the images below. Third case, a 62-year-old female presented with complaints of pain in left shoulder with difficulty in joint movement, especially inability to lift the upper arm. On clinical examination, the patient was unable to abduct the arm above the shoulder level and complained of pain on external rotation of the arm. Imaging feature, the patient was made to sit straight and the arm was examined in neutral and cross position alternatively. Sonographic examination of the left shoulder showed full thickness tear of the supraspinatus tendon with retraction of the fibers. Thickening of tendon sheath was noted. Cortical irregularity of the humeral head was also noted. On further examination of the patient in crouch position, there is evident thickening of coracohumeral ligament and rotator cable wasn't well visualized in this patient. Observation and results. This is chart age-wise distribution of patients with partial and full thickness rotator tears by age and number. And this is visualization of rotator cable in patients with partial and full thickness tears. So how much we could visualize partial thickness and full thickness tears. So in the end, in our 32 cases with ages between 30 to 80 years, the results showed that the rotator cable is readily identifiable in younger patients as compared to the older ones. Discussion: rotator cuff tears are relatively common injuries, particularly in older adults, as the tendons of the shoulder undergo degenerative changes with the age. These tears can significantly affect shoulder strength, stability, and overall range of motion, often resulting in pain and functional impairment. The rotator cable, a thickened band of fibers within the rotator cuff, play a critical biomechanical role in distributing forces across the shoulder joint. In cases of small or partial thickness tear, the presence of an intact rotator cable can help maintain shoulder stability and compensate for the damaged tissue. However, when larger tears extend into or disrupt the rotator cable, the compensatory mechanism fails, leading to pronounced weakness and disability. In this study, although valuable insights were obtained, certain limitations must be acknowledged. The small sample size reduces the statistical strength and generalizability of the findings. Additionally, the imaging assessment was operator dependent, introducing potential subjectivity in the interpretation. The absence of control group with intact rotator cuffs further limit comparative analysis and the ability to establish definitive conclusions. For further research, it is recommended that imaging technique be standardized to minimize operator bias, and studies include larger and more diverse participant pool. Comparing ultrasound with MRI could also enhance diagnostic accuracy and understanding rotator cables structure integrity. Conclusion: the summary: the rotator cable is readily identifiable in shoulder ultrasound, especially in patients with full thickness tear. It was seen that less severe tears correlated with higher likelihood of intact rotator cable. The identification of the rotator cable should be part of routine shoulder ultrasonography. The presence of rotator cable can be used as a prognostic factor when deciding on treatment plan for patients with rotator cuff tears. Patients with a visualized intact cable are likely to be better able to compensate for their cuff injury differences. Thank you.